Definitely the next half an hour, the next 20 minutes, there will be no data, no evidence, but that's where the best thing is, because as Bob say, we want to look into the future. So, okay, the next few minutes we're going to talk, you've all heard me talk about why we should do bronchoscopy, and why you've heard me talk about navigation bronchoscopy for years, but why do we have to move on to robotics? A little bit about setting up and our experience so far. So, of course, you know, lung cancer screening has transformed us. This trial was when I was still a trainee, but it actually took over 10 years before finally, last year, the NHS screening committee decided to roll it out across the country. But this has a huge impact for us because screening picks up these kind of nodules, and not just one of them, but tons of them, and we need to know what to do with this. And the volume is huge. So this is the model for East London screening program, and we've, in just this small quadrant of London, we expect to identify 1,700 suspicious nodules a year. This kind of volume you have to deal with. So I thought the best way to think about dealing with these nodules is to compare it with an established screening program. So breast screening and lung cancer screening. Now, if you go for breast screening and they found that lesion, do you think 3/4 of the time they will say, watch for waiting, come back for another scan in 6 months? That's not going to happen. But we do that with lung nodules all the time, and that's mainly because in breast, you can biopsy it pretty accurately and very safely, whereas in lung, until now, it's difficult to biopsy accurately and difficult to do it safely. So what if you have a way of biopsying it accurately and safely? Would it transform the way you approach a lung nodule? And of course, as a surgeon, we're not interested in just diagnosis. We want to treat it. We, as Bob says, we want to be able to find these things when we do the robotic surgery because you can't put your finger in it. And of course, the other concept is what if the bronchoscopy could treat it as well? So you want to be able to mark it if it's superficial, fiducial market if it's deep to help you resect it, and of course that might all be irrelevant if all you're going to do is to ablate it in the end. So there are lots and lots of navigation systems around, not just the usual electromagnetic navigation that you're familiar with, but there are actually other systems around. But it's interesting how the market has changed because Veran is probably the second largest system around, apart from the Medtronic Covidian system, and is owned by Olympus, and Olympus have already killed the program. So they can see that the future might not sit in this domain. So this is probably the largest prospective study of electromagnetic navigation bronchoscopy, and you can see the diagnostic yield is a paltry 67%. That means every three nodules you biopsy, one of them will be non-diagnostic. And so we failed the first test of breast cancer screening in that you will not get a diagnosis, you don't have an accurate test. So why is that? So there are three limitations I want to go through about the system that needs an improvement to solve the problem. The first one is the inaccuracy of where you think you are, CT to body divergence. So here I'm trying to go for that tiny cavitating lesion, and when I do the bronchoscopy, I reach the target, but when I check with the CT, I'm nearly in the liver. And the reason is, you think the nodule is there when the patient is awake on having the CT, but as soon as they lie down and have the procedure, the diaphragm pushes up. So where you think the nodule is actually the portal vein. So that is one big reason for inaccuracy. The second one, which most of you who have done it will be frustrated by, is your inability to control the catheter. It's like driving with a car that only goes at 30 degrees. So you can either only turn round, and if you want to go round, you have to go round all the time, but you can't change your direction. And here, I have a target, and you can see I'm behind it, in front of it, above it, below it. I'm everything but at the target. And this inability to steer translated to inability to be precise. So if you don't know where your target is and your car only tells you to turn in one direction, you have a problem trying to reach your target. And the third one is the unstable position. Can you imagine, you've got yourself pointing at the target in a straight shot, and when you fire, the goalpost moves. Because if you check, like when the biopsy forceps go in, you deflect away from your perfectly aligned target. Now, you can't work on a system where the goalpost keeps changing. So this is where robotic bronchoscopy, to me, have solved these three big problems. There are three robotic bronchoscopy systems around. There is J&J's Auris Monarch. There is, on the right, is Intuitive's Ion, and in the middle is a very new system, which is Galaxy's Noah. And essentially, all they are is a catheter that moves, that you can control with a robot, so that's steerability. And the difference between them is minimal in terms of the configuration. So they all have a catheter that's steerable. The size of the catheter is a little bit different. And they all, it's just like a car. There are only two controls. You either go backwards and forwards, or you turn your steering wheel. Anyone can do it. If you can go forward and backwards or turn, you can do it. So they're all very similar. So in terms of the evidence base, this is the only baloney slide there is. In terms of the evidence base, Ion has the largest body of evidence. Monarch has a smaller evidence base, and Noah is so new that the only evidence base is on a pig. So for us, in the UK and in Europe, the only system commercially available to you is the Ion, so that's what I'm going to talk about. So Ion's different from the other two systems because it recognizes its position using shape sensing rather than electromagnetic navigation. And people who use electromagnetic navigation remembers how there's interference. Your phone can suddenly make the target move, and also the dots on the board, it complicates everything. Whereas this shape sensing allows you to sense without putting that electromagnetic sensor in it. So the three problems, let's see how they solve it. The first one is directionality, how you can steer very precisely to where you want to. So here, I'm pointing at a nodule, and let's say if I do the CT, and the nodule, it says, actually, I'm a little bit above the nodule, and I need to move inferior, it's very easy. So if you look at the target, can you see there's a compass, anterior, posterior, inferior, superior, and lateral. So if I want to go inferior, all I need to do with my steering wheel is to move it 9 o'clock, 9:30 to inferior. And you see on the right, there's a ball, the trackball. You just move that to the 9 o'clock, and you point at the target. Controlling the tip has never been this easy. And here's an example. So this is, I arrived at the target, and now I have the luxury of not just being at the target. Now I'm aiming for the center of the target. If I'm not at the center, I'm not happy enough. So I move it a little bit more laterally, not quite there yet. Move it a bit more laterally, that looks good. Stick my needle out. That's the cross-section. The top right picture is the cross-section through the eye of the needle. I'm center strike on that. Now, if you can get that level of precision for a 5mm nodule, then you don't need to do follow-up imaging. Stability. That robot, not only can it control movement, but once it decides where it goes, it won't move. You saw the picture earlier when it's trying to flick it, it bounces back. And you can put a very rigid catheter, rigid biopsy forceps, the biggest biopsy forceps you can get for the target, and it won't move an inch, a millimeter. The third one is CT to body divergence. And this is quite interesting. This is not a feature of the stability of the robot. It's the feature of having an eye, a camera, all the way out to the target. So imagine an alien, a Martian, wants to come to SCTS, the ICC, right? So they, back over in Mars, they take a picture and they say, oh, Wales is there, let's go there. And they have a geographic location, and they will fly to there. But of course, by the time they arrive, it's a different time of the day. If they go to the same spatial position, they'll end up somewhere in the Pacific. So this is what the problem of navigation bronchoscopy is. You have a target of a CT scan, which is not where the target is at the moment in the respiratory cycle under those anesthetic conditions. So the best way to navigate is actually to follow the road irrespective of whether it is 7 a.m. or 7 p.m., because the road will still lead you to the same house. So if you look at this CT, you can see which bronchus leads to the target, And if you follow the bronchus, it doesn't matter if the patient went into expiration. If you follow the same bronchus, the bronchus will lead you to the target. But don't follow the ghost of the lesion, because if you follow that, you will be in the portal vein. And that is possible because the robot bronchoscope has vision all the way. If you follow here, you see that you can go deeper and deeper, and you can see every subdivisions of that road, like your GPS can, and just go endlessly. I've got to 15, 16 generation, and I could still see which turning I need to make. So does it work? So the number of papers of people's retrospective study, we're currently doing a prospective study, but this is a retrospective study. So it looks like if you just use the iron on its own, the diagnostic yield is already in the 80%. If you add cone beam CT to improve to confirm your location, to do your fine adjustments, you're up to the 90%. Well, 90% is very important because 90% is where your CT, your radiologist said they can achieve. And 90% is where the cost-effectiveness analysis says it is cost-effective to replace CT-guided biopsy. So we've been involved in this since last year. We've been participating in a clinical trial that looks at the combining cone beam CT with the iron robotic bronchoscopy. And I must say, I was quite staggered with the results too. So these are the interim results of the first 40 cases. The diagnostic yield was 95%. That is what the other retrospective cohorts have also shown. But the important thing is this procedure is so quick and easy and so controllable, our procedure time almost fell by half. And that means, what Bob was saying, my OR time's falling, I can do more cases in a day, and my managers love this. And I've never done it, yet the learning curve is so, pardon the pun, intuitive, that the learning curve is so quick that within 40 cases, the procedure time has fallen because you want something that is reproducible, easy to do, and accurate, and safe. So I'll give you a couple of examples of the kind of challenging cases that I've taken up on. So this is a gentleman who had a MI, and then as part of his cardiac imaging around the time of the procedure, there is this tiny nodule next to the pericardium on the right. So in terms of doing guided bronchoscopy, it's a bit of a nightmare target because it's next to two moving things. It's on the diaphragm, it's going up and down, it's on the pericardium, it's whacking around. So it's got this, and it's small. So it's got a really inconvenient trajectory to try to aim at and be precise. So remember, if you rely entirely on the bronchial position, you don't need to worry about where the target is on the CT. So I just follow the bronchus, and it says here, go left, and it tells me there, it must be on my left. So it tells me, if I use my virtual target, it is 2 centimeters away. But I know on the bronchus, it must be there at 11 o'clock. So I park myself at 11 o'clock and ignore that 2 centimeters. And lo and behold, I'm at the target. Because if you believe the bronchus, you're in the right place. But it's not exactly right, it's small, so I need to move it a little bit more anteriorly. So I go on my dial, I move it a bit more anteriorly, and bingo, I point at it. Very, very quick, very, very accurate. One of the features you could do is that virtual target that was 2 centimeters away, you can tell the computer, actually, I'm in front of it, move it right in front of me. So now I can believe this green ball, and I can do my biopsy looking at the green ball, and I don't need to use my cone beam CT anymore. And then I stick a needle, and even for a small lesion, next to the heart, next to the diaphragm, moving around, my needle's in the target, and I get a diagnosis of adenocarcinoma, and I have enough material to do molecular. So imaging follow-up may be part of history. The second case, which is quite interesting to show the power of this, is there is one area in the lung which is a nightmare for diagnosis, and that is the hilar node in the left upper, the one that sits between the truncus and the posterior ascending artery, because that lymph node is too far out for EBUS and very inconvenient for surgeon to biopsy. So here we are, we've got this lymph node between the truncus and the posterior vein, but there is a little window, a small window of bronchus that I know I can reach it. So what I do is I just park myself, there's a missing slide here, I just park myself where the computer tells me that is the window, and because of one, the accuracy, I can point at it, and two, the stability, once I'm there, it won't move, I can then throw a needle out and I can biopsy this hilar lymph node. And this man had renal cell cancer 8 years ago, and it turns out that this is a metastatic renal cell carcinoma, so he can have his treatment. So, in summary, peripheral bronchoscopy is useful to diagnose lung lesions. It is much more accurate now and very, very safe. So we can now review our strategy to do follow-up imaging for the majority of lung nodules. The robot have given us 3 advantages. 1 is you can see all the way. 2 is you can move it very precisely. And 3rd, once you have moved it to the correct position, it stays there. If you combine that with confirmatory imaging, your diagnostic yield can go up for 90%. And the important thing for you is also very quick. So you can do more procedures, and you can make each procedure cheaper. The future, of course, is treatment. And the ability for this to position your probe means it's the end of all those I am near it enough to ablate it. I hope my ablation shouldn't catch the needle, because every time you can now put your ablation catheter in the center of the nodule, and this would also transform the outcomes of ablation. And finally, if this robot only has a steering wheel going backwards and forwards, and as an accelerator and a steering wheel, it won't be very long before it's going to be doing it on its own. So last year, robo-taxis. I mean, self-driving cars are around, but self-driving cars that take a passenger, the legal responsibility for who's responsible for that. But yet, it has been tried out in Dubai, and this week, it's being launched in Los Angeles. This is a fast-moving area, and we need to embrace it. Thank you.